We can get started.
Yes, and so just for everyone to know, the owl is the recording device and also the speaker. And so if, just speak maybe a bit louder than you might normally do, just so that we're making sure we're picking up for the recording.
Right. So I welcome everyone to the JCC meeting for ZSFG for Tuesday, August 22, 23. Unfortunately, Commissioner Chad can't be here today, so I have the privilege of chairing, and I will call the meeting to order, ask Secretary Morowitz to call the roll, and then he'll call the topics out thereafter.
Sure, Commissioner Green
Present.
and Commissioner Christian.
Present.
And I will read the letter now. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples.
Thank you.
We move on to item 2, which is the minutes, which are the minutes of the July 25th, 2023 meeting. And Commissioner, I have corrected the misspelling error, but that's the only thing I had noted on my end.
All right, well, any additions or corrections? Not for me. Great, then I guess we'll entertain a motion to approve the minutes. So moved. And I will second it, and is there any public comment?
I'm not, yes, there's some folks online, I'm not sure if they're staff or if they're public, so if you'd like to make public comment on this item, which are the minutes, please press star 2. All right, no public comment?
Great, then all in favor of approving the minutes, say aye.
Aye.
Aye, very good.
We can move on to item 3, the regulatory affairs report.
Thank you. All right, so for the regulatory affairs report for August, you can see here we have our pending surveys listed. One additional new update that has happened since we generated this report is that our Commission on Cancer survey will tentatively be in March of next year. The committee has selected some preferred dates, and now we have to wait a couple of months for the Commission on Cancer to get back to us with a specific date, but they do schedule that in advance. So we will have plenty of time to prepare. In terms of survey activity there, you can see that on 7/12, 7/13, the American College of Surgeons had the trauma survey. That went exceptionally well. We have not officially gotten our certificate yet, but the exit indicated there were no findings. So that was a genuine triumph. On 7/24, 7/25, the Department of Healthcare Services visited the Behavioral Health Center, specifically on the 3rd floor of the MERC, and finalized their annual survey. They had started it in June, and then a couple more people came back in an unorthodox manner to finish in July. So we are waiting for the plan of correction for that, but that went exceedingly well given the transitions in leadership that they've had. And then lastly, on July 27th, CMS and in uniform arrived on Unit 4A on the SNF to do a verification survey of our recertification that they had had in June. That's one of the plans of correction. So essentially that was not so much a survey of us, it was a survey of CDPH's original survey. And we have actually gotten a plan of correction. We'll formally report it next month, but there was only one finding about offering a pneumonia vaccine to a resident. Turned out it was, he didn't want the pneumonia vaccine, but we didn't have that documentation, and now we do. So that was the survey activity for July. For the plans of correction submitted, you can see there in June, we have the 4A SNF recertification annual survey, and there were 9 findings. And that brings me to the questions. I'll just answer them as I go, and then I can answer any additional after. So the first question had been, can staff contextualize the 9 findings for SNF and the 5 for viral safety? And I was imagining you meant the frontline staff on the unit.
Well, I meant compared to everything that they could have brought up, it sounds like this is like 1% or something, and I'm just curious.
Got it.
Yeah.
So they didn't, and I think to answer both this question and the total number of items surveyed, we actually asked that question of the surveyor, and she was unable to quantify it for us. But this survey genuinely went exceedingly well. And I say that in the context that when you look at these 9 findings, none of them were directly related to the patient care. So it was things like there's a pink substance on the ice machine. That absolutely is an issue. It absolutely could cause a problem. We should fix it. We have. but it didn't cause anyone to be sick. It did, right? There were no misses in terms of the actual care provided, and I think that is something that team is, which is also undergoing some transitions, is truly proud of. So I think that to me is really the piece of it, more so than a numerator denominator situation. It really is from a significant standpoint that they really were able to come through. And in terms of the degree of the findings, I think I would say, again, pivoting back to the fact that there were no direct patient care related findings. I've called these moderate. It is possible that CDPH, acting as CMS, will decide to come back for a revisit to see how we've done with our corrective actions. So the team knows that, and we're preparing accordingly, but it's not a guarantee. It's not an automatic. It may be that they don't come around for another year, which I would say is very possible, given I know the burden they have going as many places. So we're prepared for that. In terms of whether any of the corrective action plans were challenging, I would identify under the recertification annual survey, the last one, about a full-time infection preventionist, as probably the most challenging, because it's a 30-bed SNF. It's the same state requirement for Laguna Honda, for example, that it's a all facilities letter that they had put out in the height of COVID. And so what 4A has done is they have actually designated, our infection control team is representing a portion of those hours, but the 4A team has designated one of their registered nurses to become the on-unit expert in infection prevention, which is an amazing opportunity for her. She's getting training from, I think she's doing a CDC module, and later this year something directly from CDPH, but that does come at some acknowledgeable cost, because that's a 0.5 FTE that we've now had to designate. So I would say that is probably the most challenging. Many of these others are very much kind of, we're dealing with the issue at hand, we're doing re-education, we're monitoring to make sure that staff have, kind of addressed the issue, but that one was a significant, there is a measurable cost associated with that. And I think the last one, I think I checked them all, is when do we learn if these plans of correction are accepted? So in the case of the recertification survey, I preemptively called them after about a week and a half to ask. It was accepted, so that one we know has gone through. We have not called the fire life safety. It's kind of a double-edged sword, whether you choose to, bring their attention to it to get them to scrutinize it. But fire life safety is very on top of it, and I am confident if there had been any issue, they would have reached out by now. So again, for these, you will continue to see both of these in greater detail in the coming months. I'll get to it on the last page, but just we did not convene ALCC, the accreditation, licensing and certification committee, in July. So starting in September, we will have plenty of more monitoring data than you'd like to read to report on these various findings. To flip the page to the CDPH cases, you can see there that there's been 156 total since the beginning of 2021, 36 of those so far this year. So we are tracking roughly with 2022. There were 6 new reportable events in July. So there were 2 pressure injuries on the 6th floor in med-surg, 2 sexual assaults, both in psychiatry, buttocks touches, 1 retained foreign object, specifically a vaginal sponge, and 1 delay in diagnosis related to a spinal epidural abscess. And for those last 2, you will hear more about them as they will come up, I think, probably next month in closed session from. And given that we did not have any monitoring data, that concludes my report. What questions may I answer?
Thank you. Any public comment?
Thanks. Any folks online, if you'd like to make comment on item 3, the regulatory affairs report, please press star 3. Star 3. I see no hands.
All right.
I have no questions, very clearly presented. Thank you.
Thank you. You're
Thank
really good. I just had one question. With fire life safety, didn't your lead go to Laguna and fire life safety?
Greg Chase, the
Greg,
director
yeah.
of facilities. Yes. So we have the person that was previously serving as the chief engineer is in that role now, and so they're getting their feet wet.
And so this, like, as soon as this happened when Greg had already left, or he was already
He's been
deployed.
gone for some time.
Yeah, so.
Yeah.
So he hadn't been doing it that long, and this is, 5 findings is pretty darn good for an institution like this.
It
even
is.
if it's just the SNF components.
Absolutely.
So, well, gratitude to the new leaders in that area.
I will share that with them.
I'm sure they were like,
Just to say, one of our new leaders comes from Laguna.
Oh,
So it
so
stops.
it's a little bit of
There's
class.
a little bit of, yeah.
No, thank you. I think it's great. All right, well, we can go on to the next agenda item. then.
Sure, thanks a lot. True North Achieving Safe and Equitable Patient Care. Mr. Smith is going to be presenting. I'll share the slides. Note that Mr. Smith is heroically sick and here still presenting, Commissioner. So thank you, thank him for his dedication.
Good afternoon, Commissioners. Can you hear me okay?
Yes.
Yes.
Good, thank you. Thank you for making time on the agenda for me to give you an update on our strategic priority of achieving safe and equitable patient care. Next slide, Mark. This work was defined using our lean methodology in a strategic A3. This slide wasn't meant for you to study the actual A3. It was really there to demonstrate that this is how this work was planned, designed, and all of the countermeasures had underlying project plans to implement them. Next slide, please, Mark. Our outcome metrics and targets for this strategic A3 are what forms our harm dashboard. I just want to just spend a minute explaining what each part of the harm dashboard is at a high level, and then we'll go into more detail in the slides following. So if you look at this harm dashboard across the top, there is our monthly track of these 5 harms that we have identified as the biggest risks for our patients here at ZSFG. And this is just a monthly count. Underneath that, on the left-hand side, you'll see 5 boxes with specific metrics in them, and they're divided into 2 kinds of metrics. The first are patient care events, and the second are hospital-acquired infections. And on the right side, and this is what I'm really excited that we've been able to do, is we've been able to begin our demographic stratification using race and ethnicity to really begin to see if there are any inequalities in the way that harm is experienced by patients at ZSFG. Next slide, please, Mark. So if we dive in a little deeper and look at where we are now compared to a year ago, the first is really just it's really there as a guide to tell us what's happening on a month-by-month basis. In June of this year, we actually achieved our target of being 9 harm events per month or less. And if we look at our rolling target, from the beginning of 2022, we were looking at 11.1 events per month, and now we're looking at 10.1 events per month. So we can see that we have had some reduction in our overall harm events. Okay, next slide, please, Mark. As we dive deeper into these metrics are all very specific to what happens to patients during their course of treatment in our organization. And you're familiar that we've been following falls for some time now, and over the past 12 to 18 months, we have seen a significant reduction, but we're not quite at our target yet. This year, we added hospital-acquired pressure injuries, especially in med-surg and intensive care, because we saw an increase in the amount of injuries we were seeing, and we wanted to understand where the harm was coming from and why it was happening to our patients. The trend for that has plateaued, but we really want to drive improvement in this and see that going back below our baseline. Our other 3 metrics are hospital-acquired infections, central line associated bloodstream infections, catheter-associated urinary tract infections, and colon surgical site infections. And you can see that we changed our benchmarks earlier this year, and we did that to align ourselves completely with the CMS star rating targets and goals. So the federal government set their targets annually in April, and that's when we have aligned our data from April the 1st to March the 31st, and you can see those changes there. The trend for central line associated bloodstream infections it has plateaued, and using the CMS targets, we're within we're within goal and target for that. We are still continuing to drive change there, and we'll talk about that a little bit later as we begin to talk about our armed strike forces. We have ongoing work for our catheter-associated UTIs and our colon surgical site infections. We're very close to being at target for the colon SSI infections, and we have some improvement work to do for our catheter-associated UTIs. But you can see that we have actually chosen by following CMS's metrics, we have chosen an ambitious target there. But with the work that's happening on the ICU and additional work that task force are undertaking, we're confident we can move towards that. I also want to just talk about in this part of the presentation just a little bit about some of the questions that came to me prior to the presentation. So when we look at these harm events and we look at the number of midnights, we only count each harm event once. So we don't double or triple or multiply count these harm events. They only count as once. But we do want to understand how it's affecting our entire population. So if we just reflect back on the first graph that we showed, that's just a count, 9 per month. This is standardized by the amount of patients that were at risk of being of this harm happening to them, and we used a standardized midnight census to do that, so that we can measure it with our own performance against our own volumes in the hospital. So moving on to the next slide, we then, as part of our A3 work this year, instead of having a separate strategic priority for equity, we wanted to embed equity into all of the work that we're doing. So we, with the advent of our new SAFE reporting system, we were able to start to stratify the data with race and ethnicity. I will share with you that this data is not perfect yet. There are some anomalies in the data based upon how the data comes across from Epic into the SAFE system, and there are some. We're working on how we can best demonstrate inequity in our smaller populations. For instance, in our Native Hawaiian and other Pacific Islander, that's a skewed result and doesn't represent a higher incidence of harm to that group of patients, but it does what it represents the fact that it was a very small amount of patients to begin with, so one patient skews that data somewhat. And then the challenge that we have had with using this demographic stratification is language. We have not been able to stratify all of our data by language yet, and that's multifactorial. Some of it is that information isn't collected, and some of it on all patients, and some of it is that it's collected in different places. So we're still working to integrate that into our report, and we aspire to be able to do that later this year. Next slide. One of the process metrics that we identified was that we wanted to get the data out to the people who wanted to use it more quickly. And our baseline was 60 or more days for the data to be published. We set our target to be a 30-day turnaround time. And for the last 2 months, we have been at 35 days. So we're very close to our target. We're not quite there yet. Some of the issues underlying why we're still not quite at 30 days is there are still a number of manual processes that go into producing the harm dashboard. And we're also competing with other areas of the organization who need data from teams like the infection prevention and control team. And when when the harm dashboard is in competition against teams who are using that data to actually deliver patient care, we always take a step back and allow that data to be supplied first. Next slide, please, Mark. So where are we with our metric around how many departments are driving one or more of these specific harm dashboard metrics? And what I'm very proud to share with you is out of our target departments, all of these are being driven or watched by at least one department and sometimes multiple departments. And the one area of the hospital that's really stepped up and really like embraced falls is the ED, especially in line with their age-friendly ED. It was something that they were focusing on, but have been able to take a much more organized view based upon that work that's being done there. We're currently at 83% for that, but by the end of this month, we'll be sitting close to 100%. And the reason that we're sitting at 83% is we didn't count the ED yet, but because they're in a PDSA cycle to implement that change. But by the end of this month, it will have been moved from a PDSA to one of their PIPs metrics. So we anticipate being at 100%. I do also want to just highlight that these process metrics and targets for these focused areas of med-surg, ICU, ED, psychiatry, 4A and peri-op are not the only areas that are working on and participating in this work. I want to make sure that our rehab teams of physical, occupational and speech therapy, our food and nutrition services team, our pharmacy team, infection prevention, DT, that information technology, facilities and EVS have all been active participants in a lot of this work. Okay, next slide. This slide, I really want to take an opportunity to focus on the people who are actually doing the work and these harm task forces. Prior to the pandemic, we had harm task forces that were associated with specific drivers, and a lot of this work continued operationally, but wasn't being monitored and followed through the pandemic. And we have taken the opportunity of this strategic priority to bring these teams back together and then bring these teams together in a strategic reporting structure. So for hospital-acquired pressure injuries, our team lead and our champion is OC Gabrielle, and she and the team have implemented over 10 countermeasures in ICU and in med-surg, including skin rounds, equipment updates, repairs to and preventative maintenance on a lot of the equipment that can affect hospital-acquired pressure injuries. For falls, Dana Frazier and Lawrence Child have been really championing that, and I stepped out of the falls committee to join this meeting today. We're actually combining the safe patient handling and the falls work because there's so much similarity between the work that we do. And we've added 4A into this, and their change in leadership has really driven some exciting change on 4A to look at how we can begin to focus more and understand the difference between a long-term care setting and an acute setting, and devise potentially different countermeasures in 4A. For our catheter-associated urinary tract infections, Elaine Decker and Lisa Winston are our champions. There have been some exciting work that's been done in the last few weeks with applications to automate and standardize how urinary catheter orders are placed in Epic and how those orders have some automatic discontinuation criteria set into them, so that helps both the providers and the nursing staff to follow how long a urinary catheter has been in place and whether it's still required. For our central line associated bloodstream infection, Shirley O'Donnell, who is our our champion for this task force and who does so much of the work, has been integrally involved in planning for this. And the unit engagement and line management on the med-surg floors and the ICU have been phenomenal in how not only we've really focused historically on how lines are inserted, and we're continuing to focus on that, but focusing on the care of lines after they've been inserted. And Shirley's been a huge piece of that work. And last but not least, our colon SSI group, led by Dr. Palaniappa and Dr. Kumar, have also been championing the early recovery after a surgery, or ERAS workflow, and that's going live electronically in Epic as well. So those teams have done so much, and having those teams, either new teams that have come together for CLABSI and HAPI, or revitalized and added new members with enthusiasm to the FORS, colon SSI and COUCHI groups, have really made a difference to the care our patients are receiving. Next slide, Mark. So just to share some data, 3 high points of data that we've learned over the last year or so, is the first piece. It was where are our HAPIs occurring on our patients' bodies, and we know now that the majority of them are either on the sacrum or the coccyx, and that has been really fundamental in helping us understand what interventions we need to plan for these patients. And we were not centrally monitoring the location of these wounds before. It was, of course, part of each individual's patient's care plan and plan of care, but there was this data was not being centrally monitored. So knowing this has helped the application of resources to make some countermeasures associated with that. For catheter-associated urinary tract infection, we really looked at the volume of those infections by department. And whilst ICU has the most infections and the most urinary catheters, med-surg have a significant amount, and that's why the provider groups and nursing groups are looking to replicate some of the work that's being championed in the ICU in the med-surg, because we recognize there's significant risk for our med-surg patients too. And lastly, for falls, we have identified that toileting is the biggest vulnerability for our patients. So when they get out of bed or move from chair to the bathroom is when the majority of falls. And again, that helps us to think through, plan, and implement some of those countermeasures. So centralize this knowledge has been so important to the work that we have been doing. And again, this work hasn't just been done by the providers and nursing. We have to acknowledge all of the other disciplines that have been involved in these task forces and in the work that's ongoing. Mark, next slide. So what are we going to continue to do, and what new things are we planning? So we continue to have our patient safety strategy meetings, and they're monthly, and different groups report out each month, and we'll continue that through the end of this year, and through Hoshin decide on how we'll structure that moving forward. All the 5 organizational drivers will continue with the task force stakeholders, and we'll add and supplement resources to those teams as needed. There is a need for continuing education on how to get data from our SAFE system, and actually today I've been involved in 2 conversations in 2 different meetings on what data is available and how we can look at that data. So that will be that work will continue. Risk management and patient safety and the whole of quality management will be working with other departments on how to access their reports. Some core educational modules are being developed cross campus, and they're patient safety focused. The first one that we are almost complete in putting together, quality management have coordinated, and that will be a training for certified nursing assistants around the principles of patient safety, and that will be delivered by staff from quality management moving forward once it's been approved by DET. We've partnered really strongly with the lean with the KPO in how we can integrate patient safety into our daily management system. Will Hewen and Dana have been an integral part of that conversation. And when we round on units, especially in med-surg and ICU, we see them following some of these metrics and discussing on how we can begin to change the way that we work, especially focused on falls and HAPI. And then lastly, we continue to work on how we can integrate language into our data so that we can not just report out on race and ethnicity, but on language too. So we continue to work with our vendor and with the Quality Data Center to work on that and to hone and finalize that language data for the harm dashboard. So last slide, and then I'd love to clarify anything I've not been able to do as I've presented, and then answer any other questions. And that's how this falls into Hoshin this year. And I think we absolutely recognize that we need to continue to prioritize HAPI and falls on the harm dashboard and as part of Hoshin this year. I think what we would like to do is consider the rationale to transition hospital-acquired infection metrics into the departmental PIPS reports as drivers for 2024, so that as an organization, we can still continue to follow them on the harm dashboard, but they would be watch metrics at an organizational level, but drivers at department level. And I think as I think about the process that we go through for quality management and performance improvement, when something becomes operationalized, it doesn't mean we're not still working on it. It means it's become part of what we do every day, and that's the next step in this journey. So that from a multiple department levels, we integrate this work into what we do, just as part of our kind of daily work, as opposed to it being a specific project for performance improvement. When we look at our true north, which is to improve, sustain and improve our CMS star rating, when we've done a lot of analysis into where we have the most opportunity to improve, especially based on some new guidelines that will be coming out next year that will be held against. We believe that sepsis should become, in some way, shape, or form, a new harm dashboard driver, with a focus on outcome and compliance with best practice and treatment guidelines. And this is multifactorial. I think we learned things in COVID that were not the same that we had learned generally about sepsis. COVID patients with sepsis that with an underlying diagnosis of COVID did not do well with a large amount of fluids early in their resuscitation. And that is best practice for a generalized sepsis picture. So there are some changes coming up next year in the national guidelines, and we have recognized some changes and some caution that we had shown with some of our respiratory patients when they were presenting to us, where we have some opportunities. We have stakeholders in the emergency department who want to address this change. So we're confident that this is something that we can make a difference. And again, make ZSFG a safer place for our patients when they come to us with significant illness. Now, I've said a lot. I think I answered some of your questions. I'm sure you have more. Dana Fraser should be on the line, as should Jessica too. Dana can talk about the actual implementation, and as can Gabe and myself. And then if there are data questions, I would ask Jessica to help me answer some of those. So I'll hand it back over to the commissioners.
Well, thank you so much for this great presentation, and also for being here. We hope you feel better. It's an example of how people at the general, step up regardless of what else is going on. So please feel better. Is there any public comment on this item?
First on the line, if you'd like to make comment on item 4, please press star 3. Okay.
I guess I had 2 questions. One is, can you better explain one of these outcome metrics and targets graphs? In other words, where I'm a little confused is, I know I see these light gray or purple lines, which are the metrics that are CMS mandated, and are we using the exact same metric? Because we've got the midnights, and I can understand whether CMS does the same thing, so how do we relate to it? And if this purple line is like for the central line infections is CMS related, it's kind of interesting that they've upped the number that's acceptable, if that's what it says, even though that seems to be more likely to lead to sepsis than some of the other items on the list. So, you know, like hoppy. So I'm curious to know how that works.
That's a great question. So if we look at the home dashboard overall, which I think is slide 3, the two driver metrics that fall under patient care events are not directly associated with star rating. The 3 under hospital acquired infections are directly related to star ratings and have a direct correlation with our star rating. So what I will say is that the targets that we were following up until April this year were our own internal targets based upon our prior performance and benchmarks that we were obtaining from multiple places. That could be Leapfrog, it could be CMS, it could be other papers that were published. Some of them were correlating with CMS's benchmarks, and some of them were not. As of April of this year, our 3 benchmarks, which are the lines that you see changing on the harm dashboard, they directly correlate. They are CMS's targets. So we know that we're aiming our performance improvement at the targets that are being set for us by the federal government. And we'll continue to follow those targets until April of next year, when CMS release new updated benchmarks. They may change, they may be different. We don't know yet, but we'll adjust our targets based upon that. And that's really to keep us focused on our true north, which is our star rating. And all three hospital acquired infection rates are now what we term standardized infection rates. So they've been risk adjusted against national data, and it takes into account the census of hospitals that are associated with it, the amount of patients that are at risk, and then it's risk adjusted dependent upon other comorbidities. And the reason that we do that is that it gives us an idea of how we're doing against other organizations. The downfall of using an SIR is that if other organizations find something that's working and do much better, we may look worse compared to them, or the countenance could be completely reversed. And if other organizations nationwide, if their performance drops and ours doesn't, we could end up looking better against them. But it truly is comparing us to other organizations across the US. Does that answer your question, Commissioner?
Yes, and you actually started to answer my next one, which is twofold. First of all, do you feel we're being properly benchmarked? In other words, I know the type of patient of hospital we are. When you look at the star rating itself, you know it's corrupt based on what we know about how this institution works. So what's your opinion about, you know, our peer group? And then also I was going to ask about best practices, because this is terrific work. And when you just said, well, some places might have more innovative solutions we're not doing, how is the organization of hospitals that are like ours working together? Because if we can, you know, other people who use lean, other people who develop best practices, can we save ourselves some time and help others by sharing this work? Is there a structure for that, or what's your thought about those 2 questions?
2 great questions. I'm hesitant to comment on whether I think the federal government are always entirely fair. I think that in this situation, they're using real data from real hospitals that they're collecting in the same way. So I'm confident that we're being compared fairly to our peers. There is an ability within some of the data sets that we acquire to look more closely at different subsets of facilities, and we met with we met with our quality improvement organization just last week to begin to collaborate with them more on some of our star rating metrics. So not just the 5 that are on the harm dashboard, but we're also looking at some of our readmission data so that we can compare it to facilities more like our own as opposed to just everyone across the US. So that was I think that answers the majority of your first question. The second question is about best practice. And the harm task forces that are described, I am humbled and in awe of the subject matter expert knowledge that the people on those harm task forces have. And I have absolute trust that they're using all of the resources that are available to us from Visium, from our quality improvement organization, from IHI, and from all of our academic partners as part of our partnership with UC to make sure that we are using best practice. And one of the things that I think super important for us as a public hospital, as a safety net hospital, is when we have conversations about what best practice and what aspirations are, we always have to consider resource and success, but that doesn't, in my experience in the almost 5 years I've been at ZSFG, it has never affected our aspiration to be the best that we can be. So I'm confident that the leaders in those harm task forces are aligning best practice here at ZSFG with the best that's out there.
Well, no, I appreciate that. And I was wondering if you have, others to teach. I mean, we've really been at the cutting edge of our race data, of our SOG data. And I can't imagine that other hospitals around the country have, delved into just some of those aspects as you're trying to do here. And I wonder what we have to share with them rather than what they have to share with us.
I believe that we are at the forefront of using our race, ethnicity, and language data to affect care. And we have such an active equity council, and we embed equity into everything that we do. And I can see my colleague Andrea Turner nodding because she really is one of the leaders then in this, along with Susan Ehrlich, and they can speak far more eloquently than I on this. But working at ZSFG is the fact that we consider equity in all of the work that we do is just inspiring.
Yes.
So I'm confident that I'm confident that we are forerunners in what we do.
And about those hospital comparisons.
Yes, so I'll make a brief comment on that. For many years, Congress and CMS have recognized that the star rating is flawed when it comes to comparisons for hospitals like ours. And if you look at, if you take a group of safety net hospitals, like for example, the ones that belong to America's Essential Hospitals, and you look at the bell curve distribution of star ratings for those hospitals compared to the total, there's a left shift. So it's very clear that there are issues with the way the star rating is constructed. And it's for that reason, for as long as I've been here, we've had long discussions about, well, should we use the star rating for True North? And in the end, we always decide to keep it because it is a very public metric. It's widely cited and used. And as Adrian says, we have very, big aspirations for it. CMS has tried to adjust the star rating the way they do it on many occasions, and nobody can agree the best way to correct it. So, if I recall correctly, Adrian, there was one point in time back years ago when they suggested a change, and that would have made us a 3-star hospital, but they didn't actually go fully through with it formally. So, we reverted back to a 1-star hospital. I think this is going to be an ongoing discussion, and as there's more acknowledgement and understanding about how social determinants impact healthcare overall, that this conversation will evolve. But the bottom line is, right now, we know it's a flawed metric. There's no agreement for how to fix it, and we will continue on our path to be better using it.
Great. Well, this is such incredible work, and I would hope that we find a way. So many institutions around the country are committed to health equity, but they don't know where to begin. You are so many legions ahead of what anyone else has done. So I would hope that we could share some of this so that other institutions can benefit, across the country. And we will look, now I'm Dr. Chow, we will look forward to your future report, which will come back in 6 months, right? Something like that.
Great.
So, put that plug in there. All right. Thank you so much.
Take care, Adrian, feel better.
Thank you.
We can move on to item 5, which is the CEO report and emergency department newsletters.
Good afternoon, Commissioners. Susan Ehrlich, CEO of ZSFG. And Adrian's presentation couldn't have been a better segue into my report, which starts with the CMS star rating. And it's actually, I have a lot to say about this, and I'm glad we have a moment to pause on it, because I actually think that this movement from 1 to 2 stars is the best evidence we have of the overall success of our HOSHN work and our True North strategic work over time. It's a very complicated rating to change, especially for a hospital like ours, and especially in the midst of the pandemic. So the pandemic, I mean, there's plenty of public reports showing that that bad events increased during the pandemic for obvious reasons. Hospitals were focused on COVID and not on improvement work. The star rating itself is a very complex composite made up of more than 40 metrics, and that are all weighted differently. And the data that goes into it is spread out over time. So a lot of the current star rating is actually based to some extent on data that we produced during the pandemic. There was a pause in 2020. So it's 4 years of data, 40 plus metrics. And the only way you change something like that is by, a really detailed focus effort. So you have to understand what the 40 metrics are. You have to really understand what your performance is in those metrics. And then you have to have an organized approach, as we do, to improve them, right? And I mean, I can't explain it any better than Adrian did, and I can't, it doesn't get demonstrated any better than the work that we've done on quality and safety over time. And there are similar stories to be told in other parts, like in our flow work and our, workplace violence work. So it's all there, and it's just a great testament to that. These areas that we listed here, these areas are really the ones we're calling out as the best explanation we have for how we moved. And the mortality is really important. I just want to mention one piece of this, because you don't really think about the quality of your data being important, but we've had for a number of years now a focused effort on our clinical data integrity. And of course, Epic helped a lot with that. So that data focus on data equity was another thing that added to our ability to improve in the star metric, because years ago, we didn't really accurately capture in our coding how complicated our patients were. And so through focused, efforts with providers and by having Epic, I think, we were able to do that. And so that helps us with the benchmarking, right? Because the more complicated our patients are, the easier it is to show how well we're performing. And then care experience, we do very well, relatively. Safety of care, we do well, relatively. And kind of shockingly, timely and effective care, that category we actually did well on. We cited the vaccination for COVID. There are obviously other areas of this metric where we don't do well at all. And we'll talk about them later in my data report, but this is the best way of explaining why we did better. And that was a question that you had, Commissioner Green. You can be assured, as Adrian mentioned, sepsis being kind of the upcoming thing. Sepsis is an area where we're not doing as well as we we need to. It's part of the star rating, and so we're going to refocus our organization-wide efforts there, and continue the other work as we go along. So the star rating is a big deal. And we really want to celebrate it. It's a little funky to celebrate 2 stars out of 5, but for us, it's because of all the things we've been doing. And so now our effort is going to be on keeping 2 and going to 3. And we'll just, march ahead. I think the other question you had was about how we've communicated about this. And we've done that pretty broadly. A few weeks ago, I wrote a CEO note on that, so that's published on Mondays. And then it gets amplified through our daily digest. It was mentioned at the ED huddle. So we've definitely talked about it a lot throughout the organization. Any more questions about that?
I guess, one is with the diagnoses, I think with the RAF scores, they're gonna start limiting, at least for MA, they're gonna start limiting the number of diagnoses, like their CMS is getting rid of about 2,000 of them or something. Will that affect our acuity numbers and, our mortality numbers, because they should be better because we don't game those diagnoses like so many institutions do?
Right. I don't know the answer to that question, but we can dig into it a little bit more. Jessica Toe, who I know is here, is our expert who really understands how these data all come together, and so we can take a look at that.
Great. Thanks.
But you're right. I mean, we use our clinical data experts in a different way than a lot of other hospitals do. I'll leave it at that, but we definitely want to make sure that the data reflects exactly how sick our patients are, no more. So the surveys, we already talked about, that trauma survey is only once every 3 years. So people are real nervous about it, especially because, we are the trauma hospital for San Francisco, but we did just beautifully. And we talked about the STAR, the skilled nursing facility, survey as well. The NICU Gold Star Award winners, this is for going above and beyond to collect and submit data. So when we talk about like what our best practices, are, we share with other places, this is, I think, an example of how we do that. I wasn't able to be here for the Dr. David Sanchez Way, but this is a beautiful photo, and we're so happy to recognize Dr. Sanchez. That sign is there, it will be there in perpetuity, and so we'll all be able to remember him every day. The heart that's up on our mezzanine is really lovely. It was the commemorative heart for 150 years, and it's nice too because it's in that place where you can see it from both sides, and it is actually different on both sides. So I invite you to check it out when you're in the hospital. And then last but not least, I'm so grateful to our wellness center team. This time in healthcare is really, really hard on our workers. They're working really hard, they're burnt out, distressed. This is a national phenomenon. And the creativity and energy that our wellness team has is really phenomenal. So they have yoga courses and Zumba and hand massages and service animal days. I mean, the kinds of things that they come up with for folks, including food, of course, is really, really amazing. So I just wanted to give a shout out for that tiny but very powerful team. Any questions before I go on to the data? Okay. So the emergency department is busy. It was 189 average in July. I mean, we're definitely back to what we were before the pandemic. 182 so far in August, so we're not seeing, a continued rise at this time, but that could change. Admissions is not up. It's kind of, it's this, I think this would reflect a seasonal thing. We have a lot of people coming to the ED, but they're not sick enough to be admitted. Moving on to the slides we tend to talk a lot about. So leave without being seen and triaged. I don't have a way of knowing what the percentage is right now, but this is a big focus of effort for the emergency department. And I'm really excited to say that they have been working very hard to prepare for a Kaizen event. The first Kaizen event that we will have had since before the pandemic, to look at, well, they've already been studying the flow through triage, but this event will be the first week of September, and they'll spend a few days really studying what's going on and, you know, working on improvements. So that will directly affect us. And this is part of, you know, what would be included in some of the star rating stuff. So it's indirectly there. Diversion, you know, I mean, this is a beautiful graph trending down, and sadly, in August, we've had a few more struggles. So the month to date today is 53.5, which is just above what EMSA is hoping that we achieve. There are a million reasons for that, you know, the usual things. It has to do with boarding and staffing, and, you know, a number of events that impact us. So we continue to work on it. You know, we continue to focus on those countermeasures, which involve, you know, trying to limit the amount of diversion we have during the day, having every 2-hour meetings. So it's still a focus of attention, but it's really hard. Because it's not by any means, you know, the circumstances that impact this are just not under control. So, urgent care, and the transfers between urgent care and ED are going well. There's not a big change there. So PES encounters, admissions, I think the big issue in psychiatry has to do with lower level care days. And so I think I'll defer there, because really what happens in these areas is impacted by what happens upstairs. So moving on, the med-surg census remains high. I think, you know, normally we'd see like a trend down this time of the year, but we really haven't. And we know that, you know, the census is high primarily because we have a lot of lower level care patients, and we can talk a little bit more about that. Intensive care, though, is, you know, experiencing a seasonal downtrend, which is great. We don't want everywhere in the hospital to be busy. Maternal child health is, you know, very strong volume there. That's a place where we want to have more volume because we have the capacity to accommodate it. But let's focus on lower level for a minute. So if you look at these 3 slides, and you know, they're divided into decertified and administrative days, and the reason they're divided that way is because for the administrative days, we get a little bit of reimbursement. But really, what affects us most operationally is the addition of those 2. So if you start at the beginning of these charts and you go to the end, if you add those numbers up, med-surg, we have clearly seen an increase. So it's 27 versus 66. And there are many reasons that our lower level care numbers are going up. There's, you know, we have every day we have a lot of skilled nursing patients who are waiting, but we have every kind of patient. They're waiting for residential care. They're waiting to go home. They're waiting for acute psychiatry. Gabe can tell this story better than I can because he works there every day. But it's a really challenging circumstance right now. Part of it is Laguna, but it's not the whole story. Acute psychiatry is experiencing a similar thing. And it looks like the administrative days are going down, but truthfully, like you can see a lot of variation in this pattern. And if you do the same thing there, it's 36 versus 43. And I know from, you know, speaking with Dr. Leary and my colleagues there are more patients stuck in acute psychiatry now than we've seen previously. And there are complicated reasons for that. And they're waiting for all different levels of care, but it's not better right now. And I will say we're working very closely with Lori Cummins and her team, because her team is, you know, helps us discharge a lot of these patients when they're going to placements. So that's working pretty well. And the skilled nursing lower level is pretty much exactly this. It hasn't really changed over time. The other thing I want to point out is So our COVID census today was 11, so it's not the highest it's been, it's not the lowest it's been, it's kind of the medium. And that makes sense because we know there's more COVID in the community. And the big impact on us is really in this last slide on page 20. So if you see, these employees in occupational health services management, you can see that number, it was really high, it's come way down. Well, today it's 105. So we had 11 new cases yesterday. So we have been having outbreaks, sort of around the hospital. So this is a big impact on us. We're not seeing it in hospitalization so much, but we're really seeing it in our staff. And, this is another reason it's hard to staff because staff get COVID, they go out. So it's not as bad as it's been, but 100 is a lot worse than it's been recently. And then last, the workplace violence activity. We've talked about this before. This is data out of the SAFE system. So we talked about either last time or the time before about not having data out of SAFE. Now we have data out of SAFE, which is great. We are going to refine these data so that it's more detailed. So for example, the gray line is total workplace violence assaults. The lower line is physical assaults with injury. We want to see these injuries broken down into, severe injury versus minor. So we're working on that, but I just wanted to point out that the workplace violence group, led by Andrea Turner, is making a lot of headway here. Great. So that is it for me. How can I provide more clarification?
Any public comment on this
Thank
item?
you. Folks on the line, we're on item 5. Please press star 3 if you'd like to make comment. Star 3. Don't see any yet.
Such interesting outcomes and data. In our office, the cases of COVID positivity are just going up. We've been in outbreak status for at least a month, probably a little more than that. And it doesn't show any signs of changing. And so,
Sorry.
well, and fortunately, people don't seem to be getting really sick. Right. But, they're out and they can't come into the office, but many people can work still. So it's concerning to see and to think about what we're heading into as we head into the fall and winter. But
Well, fortunately, it sounds like soon we'll have a new reformulated vaccine. That would help a lot. Because, I think people's immunity is waning at this point. So we'll hope for the best there. And we'll definitely have a very concerted effort to get people vaccinated, both with that vaccine and for the flu.
I just wonder what we're gonna do, what you do when there aren't enough beds in the community for lower level of care. And more people come and the work that's being done in the community is trying to get more people seen. And so it seems like it's just gonna continue to kind of expand and push the edges until there are obviously more resources in the community.
Yeah, it's kind of like every day our folks have to get more and more creative and work harder and harder to figure out how to construct the best discharge for our patients, and continue to allow to bring people in. I mean, you should say something about that.
Yeah, no,
You're
it
there.
is I would say a multi-pronged approach, kind of teams doing their best, kind of collaborating with all of the specialists that are on board, whether it be physical therapists or social workers or care coordination nurses, to mobilize resources to try to construct creatively plans to kind of, instead of going to a facility, we are now changing our approach and trying to support this person in the community, just because resources are limited and we can't keep all of our patients in the hospital forever until they're fully healed. And so folks have been challenged in terms of trying to be as creative as possible, and trying to mobilize and use all of the resources that are available to try to kind of support, all of our patients and balance, the kind of judicious use of a hospital bed or an ED bed, in concert with kind of the patient's needs and kind of what we can do to support that person. So it always kind of, I'm always surprised and also pleasantly surprised, I would say, and kind of impressed by how those teams come, like all the teams come together to mobilize and to kind of work collaboratively with patients, their families, kind of whatever social network or support network the patient may have, and the patient's strengths, and then kind of move from there in terms of how can we, what are the gaps or what are the needs of this person, and then how can we bridge those kind of in the community versus if not, then kind of waiting for those very rare placements that are very difficult to come by. So I think kind of in addition, I feel like Susan has really kind of mobilized our team to kind of support Laguna in the recertification process, and kind of then advocating. So we're kind of making changes to our electronic health record to learn more and kind of more granularly, what are the resources that our patients are discharged to, so we can generate reports to then kind of better advocate for kind of, this was the plan. The plan was to send this person to medical respite or a sobering center or an ADU or a shelter, and kind of really kind of see at a kind of population level from our hospital, what are the discharge dispositions of our patients, much more granularly than the codes that we have now. And that might probably open up an additional set of work for our organization in terms of thinking about kind of the needs of our patients and kind of how can we either advocate for more of a certain type of resource, or kind of identify patients get stuck and kind of trying to figure out if we could kind of, instead of waiting for this resource, these types of patients, usually we can get back to the community. Let's just do that from the beginning, and not kind of spin our wheels for too long and really trial this, like maybe not, and like what folks may say is ideal, but like the next best, or kind of as best as we can mobilize, kind of using all of our ethical principles and weighing kind of the beneficence and maleficence and all kind of the other ethical principles, doing what probably where we can bridge the gaps that we see in terms of patients' needs, and test out kind of trying to support patients maximally, respecting their autonomy first and foremost. So I think it is a very multi-pronged approach, and so I think we're learning more with some of the changes that are coming down the pipeline as well.
Yeah, just to speak to that briefly, I mean, there's so much hope on the horizon. So we've been working really closely with BHS, Behavioral Health Services, and we've never been working more closely with San Francisco Health Plan. And that's really important because they are our partners in creating that network of care to which we're discharging. And then CalAIM, with the changes in Medi-Cal, makes more and more resources available for the services we need. And then, we are making changes in Epic, and when Behavioral Health Services goes live on Epic, in April, that's going to be a game changer too, because we're just going to have a lot more visibility into what our patients need for that subset of patients. So there's a lot going on, and it's just we're constantly dealing with what's there, trying to do improvements as we go along. So we'll do our best.
I imagine the way that you're collecting the data, you can show to the policymakers, this is what we're really lacking. We're lacking in everything, but if we had more of this, we could send people to an appropriate place. I mean, I think that would be for people who are not physicians and who are in the area of policy and politics. I think something visual like that would be powerful to bring, for instance, to a board meeting.
Just to remind us, the real root cause of all of this is the lack of housing. Actually, our national expert on this, Dr. Martin Michel, was testifying today at the state legislature on this topic. So, that's a pretty big hurdle, but it's important to remind ourselves that that's really the major root cause of all those root causes were not.
Thanks so much.
Yeah, I had, two questions. One is, this new RSV vaccine is being rolled out. I mean, they just approved it for pregnant women, and there's some thought about what to do with peds. I guess there's a monoclonal antibody as well. How, as the winter season approaches, how are we gonna plan it? It's like we've got, our flu shots, we've got now RSV on top of that, plus the new COVID vaccine, and that is so demanding of the staff, and as well as everyone in the clinic. So I'm curious to know, and obviously that impacts pediatric hospitalizations and older adults.
I'm gonna ask Dr. Day if he can comment on this.
Yeah, no, it's a great question. And I think there's two aspects of the RSV vaccine. One is for pregnant women, and then also the other is for individuals, I think over 60 or 65. So we're planning to roll both out as soon as we can. So I think as soon as, I believe both have just been approved by the FDA. And so we're just waiting for the logistics of when they'll arrive at ZSFG. We're anticipating they'll probably arrive at the same time as our flu and other COVID vaccines usually do, which is October, November. And so we'll definitely be rolling them out in all of our primary care clinics. And we're thinking now about how it will potentially work for our specialty care clinics, especially those who are elderly and at risk. So we'll be trying to offer all three across all of our clinics on campus.
And I get, from what I read, it isn't clear whether you can give a COVID vaccine and an RSV simultaneously. Do you think we'll know that by the time it comes up? Because it's so hard for patients. I mean, not that I'd want 3 vaccines all at once, but I'm just curious to know what you think.
I have not heard any restrictions as of yet. And so I think we would try to offer all of them at the same time, but recognizing that some patients may want to return back. And so we'll try to accommodate that. We aren't doing our large scale vaccination sites like we've done in the past. We're just trying to sort of do most of it at our primary and specialty care clinics this year.
Thank you. And then with some of the numbers, where I get a little confused on our ER numbers, is when you see the volume's gone up. I mean, if the volume goes up to 200 and the diversion rate goes up by 10%, aren't you seeing more people? In other words, where I get confused with these numbers is what's the absolute number? Because if we send away 10% of 20 people, it's a lot different than if you're sending away 10% of 100 people. So as I look at the average daily volume going up, I have a hard time contextualizing that. Even if the diversion rate has gone up, if we're still seeing more people, are we actually diverting fewer people versus percentage? How do those numbers work?
I think there's not a direct correlation between ED volume and the diversion rate. There are just many other things that impact that. So you can't really look at just those two things and make any conclusion. I mean, I look at the data every day and I'm always mystified. Well, why are we boarding so many people today and the diversion rate was really low? You know, so it depends on who's coming in and when and how many people are boarding. It's just it's a more complicated equation than just those two numbers.
Yeah, that helps, because I always look at the numbers and I'm trying to find how we're better, and the admission, I mean, the daily volume is so much greater as you look over the period of time, and then you see even, I mean, I've been so impressed by the diversion rate that we've had, so.
Yeah, it's really, I mean, the reason the diversion rate has come down is because of our focused process efforts. So you can't really relate it to anything else that's going on. The volumes have been high, the boarding has been high, everything else. The things that you would imagine would impact diversion have still been there, and we've been able to bring it down nonetheless.
Thank you. And then just out of curiosity, you presented, I think you still have the mask mandate for patients as well as staff, right? In my institution, it has fallen apart. Nobody's wearing a mask, none of the patients are, and many of the staff take it off in the hallways. And I wondered whether you're finding the same thing, or whether,
Yes.
as Commissioner Christian is talking about people out, and I get all the calls from my own patient population, and it's clearly on the rise. And so I'm just curious how it's working over there.
Yeah, we were just talking about this today, actually, at our, leadership daily huddle. And, our infection control, infection prevention team was, encouraging us to send out messaging, not only to encourage people to keep their masks on in the hospital, in the public areas of the hospital, which has been the rule all along, but also to encourage staff now to keep masks on in settings like this, like in closed settings, because, we're seeing this really, big increase among our staff, and we want people to stay well, we want people to be able to come to work, but it's really hard, because there aren't any, kind of policies or practices in the community right now that are reinforcing that message. And it's very hard to police, as you know, in the hospital.
Yeah, it's fascinating really to see because, I see big numbers of people in a labor and delivery room and there's a baby that has no, intrinsic immunity to anything. And it's interesting. On the one hand, it's almost schizophrenic that on the one hand, people are saying, oh, there's a rise and people are getting sick. We all know people who've gotten sick again. On the other hand, people aren't doing straightforward preventive. And we, of course, hear in public testimony at the commission level, people who are immunocompromised who have to go to medical settings. And, we can't control certain things, but gosh, in a medical setting where someone is on chemo or has a biologic that they're being treated with, they must feel so incredibly vulnerable to walk into these institutions and know that they're really only protected by what they can wear themselves.
Yeah, which would be an N95 if I were in that,
Right. Yeah, well, thank you. I'm just curious because it's certainly not the way it used to be in our environment. Well, great. So thank you so much. And I guess we'll go to the next, I've lost my agenda.
Oh, sure, of course. Item 6 is the hiring and vacancy report.
Good afternoon, Commissioners. Emma Perez, Clinical Hiring Team Supervisor. As you can see from our report for this month, our hospital vacancies have remained about the same. We're at 11.75% compared to 10.86 last month. We've hired 34 employees during that month, including having 5 separations in that period and 1 retirement. Our RN vacancy rate is also about the same, 8.7 compared to 8.1 last month. We do continue to hire P103s to fill vacancies. Our hiring managers continue to utilize different selection methods. Of course, we know the fastest way is through application review, so wherever feasible, they're doing that. You guys heard about the project with the controller's office to map the hiring process, and they have completed that, the mapping of the process. We heard from them that there's 173 steps in the hiring process. It's quite a lot of steps, and those are the higher level steps. Yes. So they're taking a look at that data to really deliver their findings. So they're preparing to do that in September. And once they deliver the findings, HR leadership will then review and prioritize based on, identifying the lower effort, high impact first. And of course, simultaneously with that project and looking at those improvements, there's all, different projects in the works to improve the hiring process, DPH-wide. There's hiring efficiencies that are being implemented. There is a team that's looking at our human resources data system to take a look at whether or not another system would work better. So there's actually a request for either request for proposals or request for bids. I'm not sure yet which one. I think they're just in the discovery phase of that. So they're taking a look at that. There's quite a lot of things that are happening at the same time, not just mapping out the process and looking at those improvements. We continue to meet with the RN hiring committee with stakeholders from the union, nursing leadership, and DPH, DHR as well to review the hiring process. We just met to review the reassignment process and see where we can, have more efficiencies in that process. So That's something that's being reviewed. We continue to meet with our hiring managers, sometimes more than weekly, just depending on, what's going on with each of the hiring managers to discuss their vacancies. Right now, the emergency unit has 3 experienced vacancies. They've made 2 selections. And again, that's just one of the areas where it's hard to find experienced candidates. Same with critical care. They've been able to, they had 5 vacancies. They were able to make all 5 selections and actually had some onboarded, with one coming on board September 16th. For med-surg, they have 17 experienced vacancies. They've made 5 selections. Some of them have onboarded, and one is scheduled to onboard August 19th. The OR has 2 experienced vacancies, and they're working on selections now. We are anticipating training programs in critical care, emergency, med-surg, and OR. They're all going to have training programs. The earliest one will be in critical care, which is on October 2nd. They're scheduled to fill all of their 9 vacancies. Then we also have the emergency care, which is they've had their cohort start with 10, and they're actually filling another 9, but starting them in urgent care. And then once they're able to bring them back to the emergency department, they'll do that. Med-surg is targeting October for their cohort, and then the OR, just again, because of their resources, they're anticipating being able to do that in January of 2024. Some highlights for non-RN hiring. We've had a nurse manager hired, a nurse practitioner, behavioral health clinician, 2 dietitians, and a therapy aide. So again, those are just some examples. I know that you had some questions or requests at the last meeting for data, different reports available to you. So we actually lost our data analyst last month, which was really unfortunate, but good for his career. So he was able to actually put together for us just the vacancy trend report, split out by the 4 areas that you guys had requested. So you see that you have a ZSFG ED vacancy rate trend comparing 2023 to 2022, as well as the critical care vacancy trend, med-surg, and OR. So these reports are basically a work in progress. We are trying to make more meaningful or have more meaningful data, but it's a work in progress. We're trying to figure out, how to get additional support for our data team, and actually building out a data team that will be able to report not just for JCC, but for operationally and just across BPH, so that we can take a look at our numbers. And then you also have the other change was to the breakout of the reports for med-surg, surgery, emergency, and critical care for the vacancies and the hires. It's a little bit cleaner. I know it's not great, but it's a little bit cleaner. So you're only seeing 2022 and 2023 on there. So that's a little bit better. But again, we are going to meet on this and work with our nursing leadership as well to get you additional information. And I know you had also made a request to look at the bigger picture and not just the 2320 vacancies, but look at how operationally nursing does fills through P103 and fills through travelers. And so because we weren't able to have this data available today, I think Jillian Otway is on the line, and she can give you at least a report of how they do that operationally.
Good afternoon, Commissioner Christian Green. I am here today to do an overview for you of the process for staffing with registry and per diems. And so I'm going to start with talking about registry. Nursing direct and registry in the context of this conversation are travelers. Registry, the nursing directors usually will submit a request for a registry to backfill a vacancy in staff leaves of absence. Registry contracts are 13 weeks full-time, and shifts can either be 8 or 12 hours depending on the units. Contracts can be extended based on operational needs and willingness of the registry personnel. I will say that we have gotten really favorable reviews from our registry. They work around the country, and when they come to San Francisco General, they are usually pleasantly surprised that we are a county hospital, and so I'm very proud of that. In addition to, they really appreciate one registry actually told me that they appreciate California because they feel safer here because of the ratios. And so again, that is something that helps us whenever we are trying to recruit registry. We've also been very successful in having registry that has transitioned and stayed here with us either as a per diem or in a permanent position. So this also helps in terms of recruiting staff. We currently have 126 registry working under contract today at the hospital in various areas. I would say that probably the 3 areas that have the most registry right now are the ED, the ICUs, and med-surg. I'm going to now transition to per diems. We have 2 categories of per diems that we use here at the hospital. The first category are staff, permanent staff that have a per diem position that is used when they work an additional shift outside of their regular work schedule. So the number of extra shifts that they work varies from individual to individual. So for example, I may have a per diem and I'm working as a 12-hour nurse in med-surg. I've completed my 3 shifts for the week. I may say, oh, I'm going to pick up an extra shift, either pre-scheduled based on an open shift in the schedule when the schedule comes out, or I'm going to fill in for someone that called in sick and the unit has asked if anybody wants to work an additional shift. So that we usually refer to as an internal per diem because that person also is a permanent employee of the hospital. The second category of per diem, we refer to these staff as external per diems. They don't have a permanent civil service appointment with us, and they only work in the capacity of as needed. And the minimum shift requirement when you are an external per diem is 4 shifts per month, and 2 of those shifts have to be a weekend. So you can do a Saturday, Sunday, you can do a Sunday, Sunday, however it works in terms of filling the gap in that unit. And then the other 2 shifts can be during the week. Right now, we currently have 559 external per diems throughout the organization. Both categories of per diem can be canceled based on our hospital census and operational needs. And an example of that is in labor and delivery. You know, it's hard to, we have a baseline staffing that we have, but at any given time, if our census were to drop, we would go ahead and we would cancel the external per diem shift first, and then the internal per diem shift. And, you know, in talking about it, sometimes it feels a little crazy, but we do this every day. So the staff are very familiar with who gets canceled, who gets scheduled, and how it's done. In terms of, let me see. I'm going to see if you all have any questions for me at this point.
I guess we should ask for public comment on that.
Sure, Jillian, before we do that, it's just protocol to check for public comments. I'll do that first. Folks online. Yeah, sure, thank you. If you'd like to make public comment on item 6, please press *3. We're in the hiring vacancy report, item 6. No hands, commissioners.
Nothing for me. Well, thank you. That was very helpful to understand. And I guess the main question I had for you is just about the controller's office and the speed with which he thinks this will change. This reminds me of To Err Is Human. Remember the To Err Is Human report where they said we crashed 2 jumbo jets a day with errors. But what really struck me is when they first looked at it, it was 46 steps from the ordering of an antibiotic to the receipt of the antibiotic by the patient. And one of the things that they did, with To Err Is Human was to streamline that and come up with, national guidelines for how you could cut out all those steps. So where do you think we are on To Unhire Is Human, or whatever this, you call this, in terms of, I realize it's, you only have so much control over this, but do you have any sense, first of all, for when we might see some improvements, and secondly, how many steps you can eliminate?
So it's a little bit premature because they haven't presented that information to the team yet. But I can say that even, just looking at the process, just looking at it as we were mapping it, we were like, oh, oh, we have this happening that, could be happening simultaneously. And a lot of times there are. And like you said, there are some things that are not under our control. There are things that are required by civil service rules that we just can't cut out. So I think, and like I said, there's already some projects that are in the works where we're, our medical policy was updated. So outside of this process, before we were sending everyone to get a medical appointment clearance for medical. And now we're saying only those who are new hires need that. So if I, have taken on a promotional opportunity and I already work for DPH, I no longer have to go and get this medical appointment. So that's something that we've already cut out. So things like that we've already started implementing changes. So I'm hoping that, that we'll see a significant change in the steps to the hiring process. Like I said, it's very hard to gauge. I can't even give you like, oh, I would guess 10%. I have no idea. We haven't seen their findings yet. And there's other work also with the Department of Human Resources. They're looking at the onboarding process itself. And so they're looking to, automate that process and implement changes there. So there's lots of things in the works right now that will impact the hiring process. So I'm hopeful that we'll see a big impact. Some changes, like I said, low effort, big impact sooner rather than later.
Any of the streamlining that happened as a consequence of the pandemic that might be kind of adopted as standard now, or is it really the civil service component? And will that help eliminate some of your 153 or 173 the steps?
So that's a good question. I think one of the biggest things that came out of the hiring during the period of COVID was that we did a lot of batch hiring. So there's a real focus on going back, and we're doing some of that now, but really expanding batch hiring. So they're doing that in other classifications as well as nursing. And just taking a look at, let's say, all of the hiring managers that have vacancies in a job class for RNs, let's say all of ambulatory together. And instead of, one hiring manager doing their own process and their own interviews and, waiting for that process to take place, and then another hiring manager doing their own process, and everybody's kind of, waiting for each of those pieces to take place, is just getting them all together, getting them on a panel, getting them all to fill their vacancies all at one time, and having that scheduled out throughout the year. So that's something that we're really taking a look at and brainstorming about how to do that for other job classes as well as the RN job class.
That's really helpful. When do you think we'll see an impact of, this effort?
I think we're already seeing an impact, like I said, because there's already hiring efficiencies that are being implemented. But as a result specifically of the hiring process being mapped, I'm hopeful that maybe even in October, as we're going to get results in September. So I'm hoping by maybe late October, November, we'll see what we can do that can happen right away. Like I said, HR leadership has to take a look at, prioritize what's doable now, what are we doing already that we can piggyback off of, and seeing what can change.
Well, thank you. I had no idea it would be potentially that soon that we would see some significant impact. So
I'm hopeful.
Dr. Chow will look forward to hearing more about it in October.
Speaking of Dr. Chow, I wanted to know, I spoke to him, he's ill today, and sorry he can't be here, but he wanted to let you all know that he would like to continue talking about what HR reports make sense, because the commission obviously has questions and curiosities. but they also would like it to be operationally, useful to you all. So he's hoping this can be an ongoing thing where, you all bring what you need, and then they can try to figure out, is that what they need? And then maybe meet in the middle somewhere. He heard the time it takes and the workload. So trying to figure out, how to work together on this.
We appreciate that. Yeah, we're also going to be meeting with Jillian and other nurse leadership to see, what is feasible on their end as well, and seeing, come back to you. And I'm thankful for that conversation, ongoing conversation about what those reports could look like in the future.
Great. Thank you so much.
One question. So it may not be possible to answer this question right now, but do you have a sense of whether the retirement rate is leveling off, or that like the number of people who are just leaving? Has there been any change in that?
That's a good question. I would have to take a look a little bit closer at our separations, like a trend. I know we always have a lot of separation or retirements at the end of June and July. They actually, Luana was just mentioning yesterday that retirements actually happen as of July 1st, because they like to take advantage of the COLA that happens on July 1st. So, but we didn't see a lot of retirements this month. So, I'd have to take a look at that and come back to you with that information.
And if I may interject, Commissioner, Luana Kim's going to be presenting to the full commission her annual HR report. I forgot which meeting in September, but in the next month. So you will be hearing department-wide, and I'll throw that question her way too, so she can be prepared.
I know so many people across the board just left whatever we were doing through COVID, because life just became too hard and too unsustainable. And I know the medical profession, we all know how abhorrently difficult that time was for you all. And so I'm wondering also whether some of the things that the profession and the hospital and the system had developed to try to cope with that might help people to have a less horrible experience as we, inevitably face future crises. It'll be interesting to see.
Yeah. We'll look into that a little bit.
Thank you.
Thank
Shall we
you.
move on?
Yes, please.
Great. Item 7 is the medical staff report.
Great. Good afternoon, commissioners. Gabe Ortiz, Chief of the Medical Staff, and I will be, as part of my report, sharing the Pediatric Service Report, the Emergency Department Rules and Regs updates, which is an item that I am bringing back after kind of input from you all and some good discussions. The Pediatrics Rules and Regs, and then the Credentials Committee report with kind of updates to some of the standardized procedures. Feel free to interrupt as I go through. Otherwise, I'll try to incorporate questions that were submitted as best I can as I present out these different pieces of my report. And certainly kind of we'll have time at the end for discussion, but feel free to interrupt if needed. So in terms of the Pediatric Service Report, it was quite an excellent report presented by the interim chief, Dr. Jane. Throughout the entire report, the elements of clinical care, research, education, and advocacy across kind of what we've talked about here as being something that we strongly identify with, a lot of the health equity, community, and anti-racism measures was highlighted. So that was really nice to see the kind of theme across the department. They have a very complex service, as most of our services do, with kind of inpatient, intensive care. Wanted to highlight their nocturnist service, which has allowed them 24/7 pediatric coverage and has been a big boon to the service in terms of being able to meet the demands of our patient population and doing so safely. And then their ambulatory service kind of really focus on their social needs, care coordination. They're really proud of their vaccination rates to kind of touch on kind of what you all have brought up in terms of really important kind of going into the fall and winter, seeing the current surge that's occurring and kind of the importance of that. They were really proud of how they maintained their vaccination rates throughout the pandemic, and how they were able to strengthen relationships with the San Francisco Unified School District. So that was really nice to see. I'll also highlight how they have integrated behavioral health for kind of their youth and caregivers in their Healthy Steps program. And that was, I thought, also a really nice piece in terms of just meeting patients where they're at and kind of bringing in services rather than the siloed nature of healthcare that kind of tends to exist. They serve many different roles, including teaching and education. They have multiple faculty awards and serve on multiple hospital committees, and those are summarized here. And then, so lots of strengths, I would say, across the service report, challenges that they mentioned, kind of their finances, pediatric subspecialty support. And so they're coordinating with subspecialists at Mount Zion to be able to bridge all of the service needs. And kind of big goals for them being patient experience, continuing their health equity work, recruiting faculty, and kind of continuing to integrate their all their QI efforts. So it's a really nice service report. Again, kind of highlights, I think, the type of values that kind of really drive our organization, and it was great to see that kind of reflected so strongly in the pediatric service report. The next thing I'm going to present to you is the emergency department rules and regs. So this was reviewed last month and is coming back because of some questions around our use of interpreter services, as well as kind of some formatting issues that resulted in a duplicated section. So you'll see in kind of the cover page for the changes, much of the changes are exactly the same, with changes, with the additions of update number 6 and 7, where kind of the duplicate section was removed, and then some of the formatting around the numbering. And then section 7, I think, is the most meaty change, which had to do with strengthening the language around the use of interpreter services across the emergency department. Highlighting that certified interpreters should always be used unless there is an extenuating circumstance. Some of those being when a patient is incapacitated and their surrogate is unavailable or cannot be contacted due to clinical acuity and the need for emergent intervention. And there may also be times when interpreter services cannot be kind of accessed in a timely way. That I think is less common than the former, where patients are just incapacitated and surrogates are unavailable. Staff, however, should always do their best to communicate patients in their preferred language. And in addition to kind of our contracted services, we have a subset of staff that are also go through testing to kind of be able to deliver language interpretation and serve as an interpreter. So sometimes you can even use staff in your local area who have been certified to be able to support the communication with our patients. So that's kind of the most meaningful change that I want to bring back. I also wanted to thank the commissioners for kind of bringing this question up. And so can talk more about that change after the report, after I complete the rest of the report. In my report, there's also changes to the pediatric rules and regs, which are much less substantial, the kind of minor changes to the organization of the department. So kind of they updated some of the responsibilities, and they updated their org chart. And so kind of more much more minor changes there. Going back to the emergency department use of interpreter services, there was a question submitted by Commissioner Green in advance around whether these changes are in line, the kind of how it's worded now is in line with the Joint Commission standard. So I kind of went through the Joint Commission standard section R1.01.01.003 in terms of their standard around interpreter service and communication with patients. And kind of the Joint Commission really highlights the importance for patients to have to receive information in a manner in which they understand in kind of a variety of different domains, not just language, but kind of cognition, readability, et cetera, literacy. And so I feel that the way that the language is structured is fully in line with how the Joint Commission has laid out the requirements for hospitals to respect patients' rights with respect to that. Moving forward, I'm also presenting to you the credentials committee report, with specifically kind of the Committee on Interdisciplinary Practice, in line with what you all are pushing for and kind of challenging our organization to kind of be able to meet in terms of best practices and kind of standard work. The CIDP is really trying to move forward in terms of standardizing the SP, or the standardized procedures across departments, to make them match, that we are consistent, whether it's OB or medicine or family and community medicine or primary care, really match the standardized procedures that exist for our NPs or PAs and other health professionals. And so what you'll see in the changes that have been made to the standardized procedures is that the language and the requirements now match across the different standardized procedures across different departments. And so you'll see that standardization in the changes that are submitted to you all for review. And that concludes my Chief of Staff report for you.
Is there any public comment?
Folks online, if you'd like to make a comment on item 7, please press star 3 if you'd like to make a comment. All right, I don't see any hands, commissioners.
Right. Well, this was really wonderful report, in particular the pediatrics, because they have such a broad range of responsibility, never mind the various ages of their patients, but also all of this, the social determinants and the things that affect children, so important in an early age, from vaccines to mental health and so forth. I think I was particularly impressed that 85% of the pediatric staff is bilingual, which I think is huge, as we're talking about interpreter services and how much more important it is for children in particular to be talking directly to a provider in their language, or the language that they feel most comfortable with. It may not be English. And so I think it's really laudable that we're able to do that without, especially with adolescents, without having a third party in there, kind of making it harder for them to answer questions in a comfortable manner. So this is a really wonderful report, and I hope you'll extend our gratitude to all the incredible work your pediatric group is doing. They're very, very great. I'm delighted to see that the contraceptive implant has been standardized. I think that's so important across all the systems. So that's a really good improvement, and appreciate that as well. So I don't think there's any motion on any of this, right? It's just informational.
Right, but there is a motion on the emergency medicine rules and regulations, and then feed service rules and regulations, and then
So-
standard procedures.
Can we approve those in one motion? Is there a motion to approve these minor changes?
So moved.
And I will second it. And I guess there's no public comment, so we will say aye.
Aye.
Great,
Fantastic.
thank
So
you.
much.
Thank you.
Great. We can move on to other business. Folks online, if you'd like to make a comment about something that's not on the agenda, that's the time to do it. Okay, no hands, and then there's also public comment. Obviously, commissioners, any other business? Item 9, public comment. Again, folks online, this is the time to make a comment about something that's not on the agenda. Okay, I see no hands. And so we're at item 10, a consideration for a closed session.
Is there a motion to have a closed session?
So moved.
And I will second it. Any public comment on that?
Folks online, if you'd like to make a comment on a consideration for a closed session, please press star 3. All right, then know that when we go into closed session, those who are on the public comment line, you will not see or hear us until we come back, but we will be back after the closed session. And Commissioners, did you actually vote?
No.
Okay.
All in favor?
Aye.
Great, and give me 30 seconds to move this over. Thank you. Back in open session, Commissioners, please consider a motion to disclose or not disclose discussions held in closed session.
I move to not disclose the discussions held in closed session.
I will second it. Any public comment?
There's no public comment on that one.
Great, okay, then all in favor?
Aye.
Aye.
And then a consideration for adjournment, which again, there's no public comment.
I move that we adjourn.
I will second. All in favor?
Aye.
Great, thank you, everybody.
Thank
you.